report as well. So I'm going to declare the meeting open to the public. Okay. And just to advise everybody that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. So just to advise members and those in the public gallery that you're welcome to use mobile devices as long as they're in airplane mode and all devices are muted. You can connect to the Assembly Wi-Fi. Password details are available on gallery rules, and it is not permitted to take photographs or record any of the meeting. Okay, item number 1 is apologies. Members aware of any apologies?
Chair, just to say Linda Dillon's running slightly late, I think, due to the policing board, but hopefully she'll be here shortly.
No problem. Thanks, Harriet.
It's the same with Colin. Actually, I had left earlier.
Thank you. Item number 2 then, chairperson's business.
And Alan, sorry, and Alan. I just realised as well Alan's there too.
Any more?
I had to leave early.
Item number 2, chairperson's business. I attended a Stroke Association event in the Long Gallery on Tuesday, which provided a valuable insight into the work of stroke services, the Royal Victoria Hospital, as well as the challenges they face. And they certainly made a strong case for a 24/7 thrombectomy service in Northern Ireland. Okay, moving on to draft minutes. Members will have the draft minutes of our meeting held on the 23rd of October at page 6 of your main pack. Are members content to agree to minutes?
Agreed.
Agreed. Thank you. Moving on to matters arising. Members will be aware of the written ministerial statement on the publication of the 3 cervical screening reports. And members, included in your tabled papers is a copy of the WMS and the letter from the Minister in relation to the publication of these reports. Nuala, do you want to go ahead?
Thank you, Chair. I was going to propose, if possible, if we could get an urgent briefing on these reports so that we could ask questions regarding them from the department, but also probably the Southern Trust and the PHA. The last time that we had questions on this, we were told that it might be best, to wait, or the answers would come with these reports. And I think it's time we revisited it in the future. And I'm wondering, there may be a further proposal down the line to hear from other people directly impacted or involved, whether informal or formal session.
My understanding is that we have received some paperwork today that the Minister is sending officials and the PHA. Is that correct?
Urgently?
Well, maybe, yeah. I'll bow to that. Yeah. Urgently.
Just to say, the letters come from the Minister offering a briefing from PHA and the Southern Trust. So it is so...
Not urgently?
Well, that's for the committee to decide. So it is how soon it wants to have the briefing.
Now, we should be able to have the briefing within the next couple of weeks if we move a couple of briefings. Now, would members be happy for us to reschedule some of the upcoming briefings so that we could fit in an urgent oral briefing with the PHA and the Southern Trust?
Yeah.
I apologise for just arriving in later. Is it possible to ask the Minister to come? I mean, he can show his true colours. He's great at giving us the sound bites about all these issues, but if he wants to come to this committee and give a sound bite here, we could certainly interrogate it a bit more, but maybe he doesn't want to come to the committee to face those questions, but we could certainly ask him. I think it would be worthwhile.
We do have the Minister coming on the 20th.
Oh, that's it. Well, I suppose we can't ask much quicker than that. So.
Yeah. Happy enough with that, and we can schedule the briefing then as soon as we can within the next few weeks. Diane? Yep.
Yeah, okay. No, I think it is important that the Minister answers the questions. I know he is coming on the 20th of November, and I think that that's important. At some stage, it probably would also be useful to hear from the women involved. again and get their view on the reports. I'm conscious that the reports are reviews of systems. There's very little in it that is about women and how they have been treated. And I think it might be useful to do that. So if at some stage something like that could be organised, it would be useful.
One of the things we could do, and I know we've done previously in the past, is to have one of the Tuesday informal briefings.
Yeah.
Do you think
that's
that would that be appropriate with the women involved?
Yeah, well, not all of these women will want to speak publicly. So I think it would be useful. I do think that, I mean, I spoke yesterday to some of the women who had actually contacted cervical cancer, and they were very emotional and felt let down by the reports. And I think that we should also give them the opportunity, as well as questioning the minister, which is essential, to talk to the committee as well.
Is anybody else? Anything you would like to add on that? So coming out of that, we're going to reschedule a couple of briefings over the next couple of weeks so that we can have that urgent oral briefing with the PHA and the Southern Trust on the reports. We'll see the Minister on the 20th and we'll organise a Tuesday informal briefing with some of the women involved for members to be able to attend then. Yep, agreed. Okay. Okay, folks, we'll move on to our next agenda item. So agenda item number 5, an oral briefing from the Mental Health Champion. Refer members to your papers, tab 5, page 18 of the main pack. And I'm going to welcome the following representatives: Professor Siobhan O'Neill, our Mental Health Champion, Dr. Nicole Bond, Research Officer for the Mental Health Champion, and Mr. Peter Cash, Senior Policy and Research Officer for the Mental Health Champion. You're all very welcome. Thank you.
Hi.
Professor O'Neill, we have about 45-50 minutes for this item, so I'll invite you. You're all very welcome, and I'd like you to make some opening remarks.
Okay, thanks, and thanks as always for having me here today. It's good to get a chance to talk to the Health Committee about mental health services, mental health strategy, and the deliverability review. So I provided a full briefing a week ago, and it was very long and it covered a lot of issues. So today I'm just going to speak to the most urgent recommendations in that briefing around the need for resources for the priority areas, particularly suicide prevention and the community crisis and suicide prevention services. I'll also discuss the implications of the reset plan as it's proposed, the emphasis on cross-departmental working and the need for more of that sort of work to address poor mental health of young people, particularly girls. Okay, so starting with the deliverability plan for this strategy. So as you know, our core mental health services have been underfunded for decades now, and we are really seeing the devastating implications of this on the ground. The annual allocation for mental health services per head in Northern Ireland is only £212 compared with £264 per annum in England. So that's a significant difference, and it's actually been worse in the past, but you know that will show you how underfunded we are. It's unacceptable, and of course it runs contrary to the goal of addressing the mental health legacy of the past and investing to save. In addition to the core services, we had developed a strategy to deliver the transformation of mental health services. The reality is that the mental health strategy is not going to be fully implemented. The 12.3 million invested represents 16% of the total that was needed in the first 3 years. But when you look at the 10-year period, that's 1% of the total. 1% of the total over 10 years we've received. The funding gaps are therefore significant, and the integration of the community and voluntary sector accounts for the largest gap so far of 12.3 million. So if you look in the table of the deliverability review, the gaps are there. So the C&V sector, again, have the highest deficit. Many actions in the strategy have commenced with working groups, plans, reviews, but the reviews are not being implemented. And my view is that continuing this cycle without the realistic prospect of additional funding may well be a waste of resources, time and effort. Without investment in the infrastructure and the staff, training places particularly, any expansion in one part of the system will create vacancies and pressures in another part of the system. The deliverability review highlighted crisis services and workforce as priorities. But what seems to have been missed is that these priorities will only be progressed if there is additional funding. And the Minister said there's no additional money has been available. So the priorities are not going to be treated as priorities, and the piecemeal work continues across many of the actions in the strategy, even though it's now impossible for them to be completed given the funding context. The situation on the ground is very bleak indeed. There's now a critical overcapacity in mental health inpatient beds. All 5 trusts in Northern Ireland have bed occupancy rates of over 100% from March 2025, and the maximum should be 85%. In a recent survey, 3/4 of psychiatrists reported daily or weekly delays in admissions and treatment due to capacity issues. Almost 9 in 10 psychiatrists in that survey experienced or witnessed moral injury when making decisions about treatments and admissions under capacity pressures. They're calling for improved inpatient provision and resources, as well as actions to address the workforce crisis. Approved social workers are engaged currently in industrial action because of the bed waits and the lack of psychiatric beds. My view, and this is also what the psychiatrists are asking for, is that there's a need for a greater provision of alternative care options, including community-based treatments, supports and housing, as well as support for people with learning disabilities. However, alongside the difficulties in statutory services, we're seeing cuts to the C&V sector, who would be providing much of these services. And morale in the mental health workforce across all of the sectors is extremely low. There are stories of community and voluntary sector groups closing their doors due to the funding crisis on at least a weekly basis. There's debates in the chambers. MLAs highlight their concern. We discuss it in this committee, but the funding situation never changes. In fact, it just gets worse every year. On top of that, our suicide rates are always a worry for me, and putting all of this together, I believe there's now a very urgent need for the delivery of the regional mental health crisis service. So that was an action of the strategy. The policy has been developed, and there are working groups there, but there's no implementation on the ground. A recent economic analysis I commissioned from the London School of Economics shows that mental health crisis costs at least 45 million in direct costs per annum in Northern Ireland. And that's only the cost to the health system, the PSNI and the families. It's not all the indirect costs then that spiral out from those crises. The cost, as you know from yesterday's news, in terms of police time is 4 million per year. And the right care, right person policy means the PSNI are changing their response to these calls. So we need effective suicide prevention interventions on the ground. We need to be helping people in crisis in a different way. So to be clear, people with severe mental illness do need specialist mental health services, the crisis resolution, the home treatment teams. However, many people who experience suicidal distress do not have a mental illness requiring treatment. And they may still be at risk of suicide, and they still present at emergency departments. Almost a quarter of young people who died by suicide in Northern Ireland had presented to an emergency department with self-harm. The data is very clear on that. People who present with thoughts or self-harm related to suicide are over 10 times more likely to die by suicide, so it's a very high-risk group. However, in 2021 to 22, over half of those who attended with self-harm or suicidal ideation were discharged without any admission. In many cases, the help that they need can be provided in the community by non-clinical staff because the distress is caused by situational crisis or long-term problems such as housing, debt and poverty. So in Scotland, crisis services provide a community-based service with problem solving and emotional support starting the day after a crisis presentation and lasting for up to 14 days. This type of intervention should be an important element of our suicide prevention strategy, and the mental health crisis service model that I'm talking about that was launched and 21 included this service. However, due to funding restrictions, our current action plan and implementation plan for PL2 just refers to more general community-based services. It's not the joined-up plan that's in the mental health crisis service. And that may well actually just refer to the working groups that we're engaging in at the minute. So we need more on the ground. The cost effectiveness analysis that I commissioned demonstrates that the cost per contact for those types of services is £392 per person. And this is considerably less than the cost for an individual presenting at an ED, which with a conservative estimate is £544 just for those contacts. I can give you all these figures afterwards, and we're launching this report too. That doesn't include follow-up services and specialist mental health services having to come in from other places to do the assessments. That's just the ED consultation. So already we can see that if we were to put in the community service, we would get a return of investment of £1.39 for every pound that we put in. And this is, again, a conservative estimate of a benefit. If 2/3 of the contact could be avoided through the use of this distress brief intervention package, it could avert costs of over £5 million per annum. And the additional benefits in reducing the suffering of people who are in distress, who would now receive a more appropriate service to address the factors that led to the crisis, are immeasurable. I also need to add that we have multi-agency triage teams, Lifeline and self-harm intervention programme, crisis cafes and walk-in counselling services, and they are all great, but they need to be wired into a network of support so that there is no wrong door. And I worry that the gaps, especially in terms of 24-hour face-to-face services outside of emergency departments, that those gaps remain. And of course there are gaps in services for young people who are in crisis who are aged under 18 years. So going on to the reset plan, the aspirations set out in the PR for the plan show that this plan could actually make a real difference. The focus on joined up activity across Northern Ireland and at a local level would be positive. However, the fear is that if it's not resourced, that the plan is to increase and streamline the signposting to those external organisations who are already under huge pressure. There's no guarantee actually that mental health services will not be cut further, that core services are going to be exempt from this plan to reduce the costs. Staffing is also an issue. The phase 1 plan includes 76 new mental health practitioners for MDTs, but only 10 training places for mental health nursing. The plan is also coming at a time when the C&V sector experiencing high volumes of referrals, including self-referrals, and they are already treating people from statutory services. So the integration of that sector is not happening in a meaningful way, and whilst the reset plan states that they are going to be key partners, the interpretation, I have to say, on the ground is that they're being asked to do more with less. There are some positive developments in the mental health strategy that we need to note. The development of the regional mental health service is making progress, and it's established local and area level collaboratives. A cost-neutral 3-year implementation plan is underway to standardise services and improve outcomes, but we have the challenges of the system pressures and the alignment with the community plans and the right care, right person structures, and they're very complex. The standardisation of data and outcomes in each of the trusts is also being progressed, but again, we should be seeing the implementation of the regional outcomes framework, which was developed as part of the mental health strategy, and it's really good. The service user consultant roles has, I feel, been a game changer. It's really shifted the energy in the room. These staff are driving a focus towards compassionate, recovery-orientated care, and they must be protected at all costs. The launch of the Psychological Professions Forum is another really positive note. However, the lack of training places and the continuing absence of core child and adolescent psychotherapy remain major concerns. I would like to see the reset plan prioritising an expansion of the psychological workforce and ensuring its influence across the key government departments, especially education, to reduce the numbers who are coming through then to need specialist services. Most people with mental health problems are cared for solely within primary care, but the resourcing challenges in general practice can be a real barrier too. While MDTs are important, they are referring into overstretched services, and that remains a problem. However, no clinical service alone can address the deeper societal issues such as trauma, poverty and homelessness that underlie the suffering. This underscores the urgent need for a cross-departmental approach, and in particular justice and education need to be involved in that. For example, the data shows that 2/3 of young people have low or slight hope. That's something that we can actually teach in schools if we were to want to do that. 53% of 16-year-old girls have probable mental ill health in the most recent Life and Times survey. We urgently need health and education to work together on the curriculum reform to ensure that young people have a well-being education and they have a resilience training in school, as they have in other regions. Prevention is a key part of the reset plan, and following the evidence, this should include a commitment to ensure that all young people have access to schools' wellbeing teams. Again, the ambition in England is for 60% of young people by April to have those teams, which will provide one-to-one face-to-face support if necessary too. Finally, our research is showing that 28% of 11 to 19-year-olds have either ASD or ADHD, and that these young people have significantly elevated rates of mental ill health and suicidality. This underscores the urgent need to strengthen the early identification of mental health need and neurodiversity affirmative practices. The proposed changes under the Children and Young People's Emotional Health and Wellbeing Framework, which I'm sure you're aware is currently at consultation phase. The proposals there provide a much more appropriate response to meeting the needs of children and young people with neurodiversity. However, as always, I'm concerned that funding pressures will result in this framework not being implemented. So, thank you.
Thank you, Professor. Quite a lot to get through there, and certainly there was a lot of concern expressed recently just with the deliverability report that came out. A couple of questions. One that came up, there was obviously 12.3 million allocated to the strategy against a target of 35 million in 23-24, including a zero spend on eating disorders. What are we seeing an effect on people with eating disorders? Is that an issue that you're seeing a rise in?
Yeah, so currently we don't have a regional eating disorder service, so people with an eating disorder are treated maybe differently in different trusts. So in some cases there are specialists, in other cases it's about an admission to a general ward in a hospital rather than psychiatric care. So the care is not uniform across the different trusts. And there are worrying examples of people who aren't able to access the evidence-based services, the approaches that would make a real difference there for eating disorders. There's a staged care approach that's it starts with the dietetic support, and then there's psychological interventions and treatments there. But I'm hearing about young people particularly young people with neurodiversity as well, which is often overlaps with eating disorders, that they're not receiving that joined up treatment that they should get. But eating disorders are really worrying because it is the deadliest of all of the mental illness. It's very high death rate. So it's very worrying when that happens. And we've heard recently about more complex cases coming through, and identification at a later stage, when that person's worryingly underweight and it's starting to affect their physical health. And this is all about early intervention or identification, particularly in males. There was a trend towards males being diagnosed at a later stage and not being diagnosed in primary care in the way that you would expect. So very, very worrying, yeah.
Thank you, Professor. We're moving towards the 3-year budgeting process. Hopefully, I'm just wondering what discussions you've had with the department, any interactions with the department about that?
Yeah, I mean, the department are clear that the money that's currently allocated to the mental health strategy isn't, as far as they're aware, being cut further. But we're sitting with the money that we needed for year one, and actually we would have needed much more. So it's going to be, the worry is we're a third of the way through, we've got 1%, another third, is it going to be 2%? Because it's not going to be implemented. And even using that money to develop plans and reviews, why would we do that? And the goodwill's running out. So people who would have been on those working groups, especially from the C&V sector, given their time to be involved. And when you think of people with lived experience as well, they're coming and they're sharing their experiences, helping design services. And the reports are brilliant. The reviews are really strong. The recommendations are very robust. But they're never going to be implemented at this rate unless something changes. And the 3-year budget is really just adding to the despair in a way, because it's like nothing's going to change over the next 3 years. But well, unless money can be brought in from somewhere else, and hopefully as a committee you'll be able to help with this argument. But the cost effectiveness of this work is well demonstrated. You know, I've shown there for crisis services alone, and that is a priority. But we're not able to do that. But for crisis services alone, you've got an immediate saving there at the emergency department level.
And again, that's something we do hear again and again, efforts to redirect people away from inappropriate admissions into A&E, but certainly it is far more appropriate for people to be seen in a regional crisis centre. As part of the committee's strategic priorities and shift left, we're reviewing the availability of a regional one-stop point for information support for mental health services. Could you provide your perspective on the PHA Minding Your Head service? Are there any gaps or any improvements that are noted?
The website. Yeah, no, I mean, there's a dilemma here, because there was quite an intensive process undertaken to understand what the best way of doing the website and digital mental health generally would be. And again, they produced a report and that's really strong and really ambitious, but we're not going to have the money for that. So we're now left with the dilemma, well, Minding Your Head's actually very good if you look at, there's a lot of really, really important information there. We also have the Children and Young People's Services website, it's really strong there too. You know, so should we be doing something in the interim? Should we be investing in adding the improvements in the digital? There's so many really good digital mental health interventions that we could add and layer on top of that. But, or should we wait for the money for the really good one that, you know, there's Spun Out Navigator. If you've looked at the Republic of Ireland, they have a very good model as well for mental health and for young people's mental health and accessing services and accessing interventions and, you know, the chat lines and everything as well. So I don't know. I would like to see us start with a really, really good model, but I don't think the funding's there for that. But we will, again, this is an invest to save thing, because a lot of this is about getting to the right source of support on the website. That's how we do it now, you know. So there's a dilemma there, but Minding Your Head's actually quite good, and maybe we should put more money in there. A very limited budget, we need to make these decisions. Yeah, but something needs to change. It does feel that it's a bit dated though. To say the least, maybe.
No problem. Thank you. I'll open it up to the floor. I have Colin.
Thank you, Chair, and thank you for your presentation. I think probably the saddest bit to note is that each time you come back, I feel you're just more and more exasperated as to what's, you know, it's like, I remember at the very first minute it was that these things are going to happen and we're going to get the money and we're going to deliver it, and then it was like, okay, it doesn't look like the money's there, but hopefully we'll achieve it. And now we're down into, I mean, the whole concept of targets is that you try and reach them, and then if you don't reach them, you can be measured by the fact that you don't. And the reset plan just simply reduces the targets, so it looks like we might be getting to reach them because they're lesser, and that doesn't feel like the best way to address a major issue like mental health. We should be open and honest about all of the problems that we have, and then we should be constructively putting things in with interventions to try and address it. And I just don't feel that I feel that the department isn't addressing it because it's just not able to, and that's for whatever those reasons are, whether it's that they're not able to get everything around the table at the right time, or whether they can't get the investment in it, or whether the numbers are going up in a way that they're not able to catch up. But the bottom line is that we're failing people because we're not actually delivering on the strategy that was there to try and address the problems, and as time goes by, all of those variables just change, and that's that is sad that we're not getting to that. But I suppose you've referenced a little bit of it maybe already, but maybe just to package it together, we are now, you know, down to the priority of the priorities of the priorities. What is the absolute bare minimum that we need to do to be, at least to be able to provide anything? What would your views be on what that bare minimum is? Because this executive and department is drawing us right down to only being able to deliver bare minimums.
I feel that crisis services, obviously, because that's where we're seeing people in crisis, suicides, you know, and if we can, and it's not actually mental health services that many of these people need. When they're assessed, a lot of them aren't admitted to mental health services. And I think the commentary around the PSNI figures and the idea that these people need a medical intervention, in many cases they actually don't. They're in crisis, maybe use substances as well, but a community intervention would be much more appropriate, and we see that happening in other countries. And if we could give them the right intervention at that time, at that opportunity, then we would be turning things around for them. And the Scottish initiative shows that that is possible and that it's cost effective to do that. So I think if we could help those people in crisis, then we would make a big difference. I also think if we're not doing the resilience work with young people, and yes, there's an argument also for, you know, preventing poverty. You could tackle child poverty and make sure that, and that would reduce some of the inequalities that lead to mental illness. But at least if we could give young people in schools right now, if we could equip them with the skills to regulate their well-being and to manage themselves and manage their relationships, that would make a difference. So I would be thinking, though, in terms of health, it's really about those crisis services and helping people who are in a state of crisis. But the workforce is another, and that's why they've been identified in the deliverability review. But if you look at that review, those priorities are not going to be prioritised because there's no money. So actually we're going to just keep doing all the different elements of the strategy, which is not really, I think, a good way to proceed. But it's very difficult to choose from the others. And I guess that's what the deliverability review found, that for every person, you know, they interview a load of different people and they all have different views on which of those 30 whatever priorities need to be, or actions need to be taken forward.
And again, it speaks to the sadness, and I do use the term sadness, that if we're saying what is the one thing that we might be able to manage to deliver in terms of mental health, and it's the crisis. You know, we're just not getting any of the other stuff, and we all know that somebody that is in crisis has had a journey to get there, and actually there would have been multiple opportunities where we could have helped them before, but we just don't have the structured capacity to be able to deliver on that. And the two other points I wanted to raise, and you've wrapped them up in your answer, so it's to do with other areas that have got good practice, and you've mentioned Scotland and the South and other things there, so hopefully we'll be able to continue to draw on that. But if there was any other, and also just about the importance of early intervention, about that, you know, I think crisis is at one end, but I think if we also had something at the other end, at that early intervention, that family support right from the very beginning, to be able to, because it just reaps rewards and it can divert X amount of % off that journey that leads to the crisis, so it has to be worth it. But do you see the value in that early and family support, and if there's any other examples internationally that you know that we should be looking towards?
I can't think of international examples, but there's strong evidence that if you support the early relationships, the first 3 years of life, the caregivers and the babies, you'll make a big difference to the outcomes for that child. And that's not just a mental health, it's education, it's criminality, it's all of the stuff it's physical health as well. You know, so the evidence is really strong. Childhood adversities, which have increased actually, that report that was out at the start of this year from Justice showed that 4+ ACEs has risen to over 17%. When I was doing this work, it was something like 5%, or, you know, it was much lower. So we have just so many families now living in poverty, and if we could feed children and make sure the environment there is at that early stage is adequate and that the relationships are supported, we'd make a huge difference. And that's early. You know, there's ways of catching that population through health visitors, through the maternity services, and then the early years and childcare stuff, and then as you go into schools, primary schools and secondary schools, getting the work in there will make a big difference as well. And it's very cost effective. Social and emotional learning and education, you get back £5 for every pound you put in, you know, and there's so much evidence. It's actually more than that, but that's the bottom end of it. So we need to be investing in that. It's cheap, but it's not something that's been discussed much, I have to say, in the chamber, certainly, you know.
Just to conclude, Chair, I mean, it's actually, I actually just feel like crying whenever we have to discuss the things, whenever we say that if we just fed children it would help. Imagine in 2025 we're saying in some instances if we just fed children it would help them with their outcomes, but that's where we are. It's such a challenge, but thank you, I really appreciate getting those updates. Thank you.
I agree, it's chilling, it really is. Aurelia?
Thanks very much, Danny, and thank you, Siobhan, for your briefing. As always, it was really useful and helpful with the detail you've provided us with. So my first question was, you had mentioned there earlier just around like the situation doesn't seem to be changing in terms of our mental health funding and the levels of mental health funding. And we know that as a health committee that over the years we haven't really seen any increase or any change around the percentage overall spend which goes towards mental health from the overall health budget. We had some of the health officials were briefing the committee the other week around the mental health work that they're doing in the department. And I had again asked them the question, has there been any change from sitting around that 5 to 6%? And they says no. So it's going back to from what Robin Swan was in post. I was asking him and his officials repeatedly, has there been, can you show me any additionality, any additional spend from your own health budget that you're assigning towards mental health? And we haven't really seen that. We haven't seen it. So my first question is basically in terms of your role as mental health champion, what lobby or what discussions do you currently have or have you had with the health minister in terms of his responsibility for funding mental health?
Okay, so first of all, the emphasis on the percentage, I feel as well, we need to be moving towards talking about the per capita, the per person spend, because the health budget's inflated. When we compare ourselves to, we're spending more on health. So that percentage, actually, it's a bit misleading. It's worse than that because we're underspending on mental health and we're overspending on health. So that's why I really like to emphasise that per person spend, how much are we spending. So that's one. And yes, I've spoken to the minister about this, and to be honest, he just says he doesn't have the money, and he would put it back in a helpful way. Like, what part of health should be cut for this? Because and it reflects back on Colin's point as well. I think we're already, in health, we're only really dealing with the red flags at the minute. Everybody else is putting a waiting list, and that's what we're going to be doing in mental health. Sort of what I'm suggesting nearly in mental health is we just deal with crisis, and we can't keep doing that. But unless there's transformation of the whole thing and more cross-departmental work and to really decide, because it's poverty, it's inequality that's driving all of these problems, and those aren't issues for the Department of Health.
Mm-hmm. Yeah, so
alone anyway, so that's he just doesn't have the money earlier. That's what he's saying. No. And I'm not across the health budget, so I can't make any informed kind of opinions on where this money should come from. Only then advise where it needs to go if it could be available for mental health.
Yes, no, and as a health committee, we're all too well aware that clearly the minister doesn't have enough money to do what he needs to do right across the health service. But it's just, I'm just really trying to tease out, I suppose, as mental health champion, do you believe that the health department, the health minister, is given enough priority to mental health and addictions?
So what I would say is that they have worked very, very carefully through the structural issues, the regional mental health service. I mean, the officials have done everything they can with the budget that they have. When you look at the preparatory work that's happened, that's really strong. What I'm sort of suggesting is, should we continue with that now that we know what the budget will be? That's a question. But the preparatory work, the restructuring that regional mental health service, bringing in service user consultants, all of that work is actually really impressive when you think of what has been delivered with so little money. So I think they're doing all that they can, and the creativity and the cost neutral options, and what can we do differently to save money and improve service users' experiences. And we can see that in the trusts. I could give you examples from across the trusts of where they are doing things differently. They're looking after their own staff so they can deliver compassionate, patient-focused care. So I think everything's happening and the minister's driving that. To be clear, you know, the officials are instructed to do that and the minister's across that. And he's, you know, he really is aware of the importance of this issue. It's the funding thing and the unwillingness or inability to take funding from any other part or find extra money anywhere else. That is the problem.
Okay, thank you for your views on that. And then you have mentioned around the cross-departmental working, which is really important, and the role that other departments and ministers should be playing in terms of mental health and indeed suicide prevention. You'll be aware that I'm bringing forward a private member's bill, which is putting responsibility, hopefully, onto all of departments to, you know, play their role in terms of saving lives by suicide. So my question is just, I suppose, maybe for your own interaction with the other ministers, Siobhan, particularly DFC, the poverty, the homeless stuff, education, you know, the wee schemes like Happy Healthy Minds and stuff. Do you have a good working relationship with the other ministers to try and help support them, bring forward positive mental health initiatives?
Well, indeed, that would be my role, is to work with all those government departments, and I have really good engagement with justice communities through the anti-poverty strategy and education as well. So we're feeding into the group that are delivering the framework, for example, the emotional resilience, mental health framework in schools, and shaping how that's delivered. But again, you know, there's that needs to be scaled up. There needs to be more money invested in that, and we're working with the curriculum reform group to make sure, and it's been set to the side for now, that the wellbeing education isn't forgotten in the curriculum reform, because that bit is absolutely fundamental, and young people are calling for that education to be part of our curriculum. So we're doing that as well. The anti-poverty strategy, and I've said publicly, you know, that just needs to be changed completely, and we need to be bringing in actions there that will improve the circumstances for children and families at those early stages and get more resources into those families who are living in poverty. So we are working with those groups. In terms of justice, it's really difficult because they're dealing with the implications of not addressing poor mental health, of not doing the other bits, and it's often really difficult to see what you can be doing there. But I would think that if we were to introduce crisis services, that would bring savings to the Department of Justice and certainly to police in terms of the amount of time they're spending dealing with mental health. So, you know, there would be savings and benefits for that department. So yeah, we're working across departments, but they all find themselves in really difficult situations, and many of these departments are having the big issues to deal with. They have to make tough decisions around where to spend their money, but where possible, I'm suggesting that, you know, for example, the employment programs, that needs to include an awareness of neurodiversity and interventions to support people with mental health difficulties and help them gain employment. So we need to be aware of that. So yeah, the work's happening, but it's slow, and we still need the treatments for the people who are ill, and Department of Health do have a responsibility there as well.
Yeah, no, thank you so much, Siobhan, for that. And then just finally, my last question. You had touched on the justice stuff and the police and stuff as well, and the social workers and their strike action, and I know you'll be well across the issue, but I think it was on 600 occasions last year across all of the trusts that there was that they weren't able actually to connect people to a service after people have been detained. That's the issue of the beds and the capacity. And then there's a handover. People are being handed over into the emergency social work service, which they can't offer any treatment. They're basically just sitting with people, you know, until a service for them becomes available after they've been detained. And I know that this can potentially last up until a week, you know, it's meant from 6 hours up until a week. So I have been speaking with some social workers over the past couple of months just around those waiting times, and, you know, even the lack of beds to get people into once they've been detained, but then that problem of the handover with the social workers themselves and how they basically just have to stay with someone, so that person isn't receiving treatment, they're just sort of stuck. And I'm wondering just if you have any feedback on that, or if you've had any conversations locally with people who have been faced with that difficult situation.
Well, the survey that I was talking about from the Royal College of Psychiatrists really speaks to that point. When psychiatrists, this is huge, when psychiatrists are saying that they are compromised, that the resource and the capacity issues are sometimes affecting their decisions around treatment and care and admitting people. That's really, really worrying. The other side of it is, though, that not all of those people have a mental health need that requires admission to an inpatient unit. And when they're assessed, a lot of them are assessed as not needing that type of care, but they need something clearly, and that's where the gap is. It's that support, it's the problem solving, it's that getting in touch with them the next day to find out what happened and how they might start to solve the problems that led to the crisis. And that's not going to work for everybody, but the Scottish model has that, and we don't often have anything there, or people are signposted to a different service, and then of course a couple of days pass and they don't go, or they aren't able for whatever reason to connect with that service that they've been told to connect with, and then the whole thing spirals out of control at a later stage and they end up in the same place again. So it's just that piece of the puzzle, and the C&V sector are well equipped to deliver those sort of interventions. It's work they want to do, but yet we seem incapable of providing them with the resources to do that, even though the model's sitting there and all the work's happening with that group to develop that service. I worry it's not going to be funded.
Thanks very much, Siobhan. Thank you, Chair.
Thank you, Orlia. Nuala?
Thank you, Chair. Thank you very much. Siobhan, for the introduction, can I ask for the figure again around the ASD kind of neurodiversity and issues of mental health, particularly around young people? It was towards the end that you'd focused on that bit.
So this is a study that one of my PhD students is doing based on the 2019 prevalence study data of 11 to 19-year-olds. And when you add up the numbers who meet the screening criteria for ASD, so who are autistic according to the screening criteria, or who say they have a diagnosis of ASD or ADHD, so hyperactivity and indicative of ADHD, it's 28.3%. It's really high. You know, and that figures, it's when you add them up, if you add on dyslexia on top of that, it actually, so when you think of neurodiversity, this is, you know, it's a big proportion of our population. So, yeah.
And so was that based on those who were accessing or awaiting mental health, or and then the 28% of those people have ASD, ADHD, or dyslexia? Or what is
they're telling us they have a diagnosis.
Yeah.
So they're now somebody might have told them they think they have, and they mightn't have. But they're saying either diagnosis of those conditions, or there's screening questions that are sort of probable hitting the threshold. So it's one or the other. And in many cases, it's actually both. So and there's very few people. I think there's like really tiny numbers who have a diagnosis but aren't meeting the screening criteria, you know. So it's robust enough, and many of them aren't accessing services, and many of those people who have screened positive wouldn't have a diagnosis, or have said they don't have a diagnosis, but the people who have a diagnosis mostly meet the screening questions.
So it does sound like there is a bit of a correlation. It seems like a large number. Or are there any other studies that show that those who are either diagnosed or waiting to be diagnosed with ASD or any other neurodiverse issues, that they do tend to either suffer or at risk of having more mental health issues?
I mean this is well recognised. I suppose it's a social model of disability. If you have a world that's structured for neurotypical people, and neurotypical people benefit in our education system in that way, you know, we ask young people to behave, and in the workplace, neurotypical people will thrive, but people with neurodiversity often struggle because of the structures and systems around them. And you find then that there's higher rates of poor mental health and suicidal thoughts and behaviours. And in fact, when you think about autistic people, those suicidal behaviours manifest somewhat differently as well. But the difference you have in your briefing pack, I mean, the difference there is huge. We're publishing a paper on it at the minute, but this is not unique to Northern Ireland, the elevated rates of mental health problems. The numbers do seem to be higher, particularly in our schools. You know, that 5% figure of diagnosis in schools, that's higher. So yeah.
And so it seems that a kind of subjective approach to actually individualised approach to dealing with mental health issues is for the best for each individual patient rather than a system-based approach. And something we find is when we speak to organisations who receive any sort of statutory funding that does exist, and I recognise that there isn't enough, that quite often they're not, in particular even in the in-house GP services that they can provide, it's very prescriptive. They have to stick within the bands of you get 6 sessions or you have to do X, Y and Z, and then you have to write your end of year report about what you achieved and the number you achieved rather than the outcomes based for each individual. And I know that there are funding issues, but are there ways in which we can do things differently with the funding that we do have so that the likes of those prescriptive services can actually tailor to individual needs?
Absolutely, and that's almost what I'm arguing around the crisis services and the involvement of the C&V sector organisations. In statutory services, there are care pathways. Services are designed, they have to be tightly designed as well so that we can make sure that staffing and funding and everything is right, and there's care pathways that need to be established. And that's just statutory services are like that. It's the same with physical health services. You go to a specialist, you diagnose and go to a specialist. Now, there's more flexibility in the statutory system than there has been before. But yeah, you're right, there are limitations around the number of treatments, what those treatments look like, who delivers them. Community and voluntary sector are demonstrating that they are much more flexible. They're able to pivot, they can increase or decrease session numbers. They provide a different type of support, a less formal type of support. Often the location of those services is such that there's access to other types of supports in the same building or in the same community resource centre. So I think the reset plan and the idea of more involvement of the community and voluntary sector is a really good thing and would help overcome those structural issues that kind of impede the statutory services. So they're treating an illness. You're treating an illness there, whereas in the C&V sector it's more intervention and support. Well, there are interventions in statutory too, but that's kind of how I see the differences there.
We see that in organisations in my constituency. I think of like PIP's Lighthouse, and there's some there that don't receive statutory funding, but some that actually don't want it because it does hinder what they can offer in terms of how prescriptive that they would have to be. So how seriously is the department and SPPG actually looking at changing the way in which, I mean, a reset plan, I agree, it's great, it is fantastic, but are we changing the way in which we do things so it is very much individualised based? Are we seeing that? Because I appreciate and I completely respect that you must call for additional funding, but I think we also need to focus on the way in which we use our funding now. But do you envisage that there's going to be a change there? Do you see it yourself that it is happening?
I am hopeful. I think the way the trusts have approached this, they're bringing in the C&V sector. They're trying to remove those power imbalances. So they're bringing C&V sector to the events, to the launches. They're co-designing the policies or the terms and conditions, I suppose, of the area collectives. They're co-designing those with the C&V sector more. The C&V sector would say there's still that power imbalance because of the need that they have to apply for funding every year, and the structures have changed. I mean,
they'd almost speak out at things that they're doing wrong.
Yeah, well, they do feel, if they're reliant on funding, that can be a problem. And now we see with core grant funding that they've actually reduced the amount of money that organisations can apply for. So that's going to be a problem if you're a bigger organisation and you've relied on core funding to fund your service. So the structures are being developed. They're in place. We're engaging with them. So, I mean, if I can come back here in January or February, I'll be able to give you a better answer as to what exactly is happening. But it's starting off well. And I think there's... there is this kind of realisation now, and I'm coming to it over the past few weeks, the money's just not there. We are going to have to do things differently. We have to accept things that we can't change and start to work with what we have. And and think about the amazing resources that we have and the individuals who work in mental health. And many of them could have left and got jobs, in other places, and they don't, because they believe in this and they know the types of changes that are needed and they know the difference that it makes. So, I think it could be positive, but it is too early to say. It's just a document at the minute, really.
Maybe we can come back to that. And one of the issues around that, then I'm sitting in the policing board and we discussed this. We have been discussing it for more than 2 years, is right person, right care. So we discussed it this morning. And I just want to ask about your input into that. As our mental health champion, do you feel that you have had enough input and that there's buy-in from the health sector in that? Because it was supposed to be launched earlier this year, it hasn't been. So what are your thoughts?
So I'm engaging with the group. I'm part of one of the, whatever it is, there's different layers to it, but absolutely. There are now structures, there's groups across Northern Ireland to look at this and what it will mean at an area level, and also what it will mean, and I've set it out in my briefing there, all of the different subgroups now that have to work to plan for what's going to happen when the police are stopped doing various different types of work. So it's very, very complicated, and my main concern is around those people who are suicidal, or who are at risk of harming others. Really, what will that look like? So it's a very simplistic kind of view. What will happen to the people who need mental health support, who the police come to now, and what kind of crisis service will be in place? And that's another reason why I think that the regional crisis intervention service model, regional mental health crisis service model, needs to be implemented on the ground to help with that. They don't even have a cost. That's really worrying, that there isn't even a figure put against that. I think when we do come to the point where we have a figure of what the replacement will need, that will be a key point then, what health will need to backfill. I think it's still a long way away, and I sense frustration as well from the police, because they see this happening in other regions. It's actually a really good model. It's about getting people to the right person. Absolutely. I would argue it's not always medical help that people need. We need to be moving away from this idea people need a hospital bed, medical help. Sometimes they do, but often they don't, and community support would be more appropriate and better for them. And I can see how this works in other places. It's just such a shame that we can't progress that here.
Okay, thank you. That is helpful, and I know that the police and people from the department are looking at the mental health suites in England and Wales, so hopefully give yourself an opportunity.
Yeah, I think it is working quite well. There were concerns at the start, and I highlighted my concerns as well. If this was going to be implemented at pace with the deadlines that were initially proposed, it could be really, really risky. But I'm much more confident now, but it's moving very slowly. So we need to watch closely, I suppose.
I get another one for us to come back to in a number of months.
Please. Well, I'm thinking about it all the time with the suicide prevention.
And I have one final question just on coming back. I was supposed to ask after the question around ASD and neurodiversity. With regards to education, early identification, trauma-informed support, culturally appropriate support is like the training. What training and guidance that you think that teachers should be adopting for the neurodiversity approaches within schools, so to really not prevent later mental health issues? And I know we're health, not education, but they're both very much linked. And with the removal of Happy Healthy Minds before, and some children were kind of cut off from counselling services they were getting, there's also a question of whether it's tokenistic or effective in some cases of what is offered. And again, back to the individualised approach, but is there any insight that you kind of can provide on that with regards to the kind of training and support for schools and teachers?
I think the ACEs 1 and 2 Solihull approach, trauma-informed practice training, is really, really strong, and that is very powerful. I mean, it's in our programme for government. I think everybody should do it. It really shifts how we see behaviour. How we view the behaviour of others, particularly children, and it's online training. It's lovely, and it actually causes you to reflect on your own background and upbringing in the context of your family and your current environment. So I think that's very powerful, and that is available and has been available for a long time across Northern Ireland. you know, and I really like the fact that the Programme for Government is talking about that. In terms of training for teachers specifically, neurodiversity awareness, it's a lot of teachers are already doing this. And it's about providing those sort of safe, secure environments in a classroom and thinking about the relationships across the whole school. That whole school approach is about safety, security, emphasising stable relationships and how do you create safety for young people, and being connected into the community and connected into parents. And often the whole school approach actually starts with a survey of what parents are finding difficult about the school's processes and working from there. And the schools that are adopting the whole school approach, it's brilliant, and it's just lovely to see. And that's part of that education framework, which is mostly funded through the Department for Education. There's the health money goes into it as well. My issue is that not all schools are getting it, and particularly when we get to second level, that the emphasis then turns to the exams and qualifications and the pressure and the stress, and then we see the rates of poor mental health just shooting up there. And there's an issue around restraint and seclusion that the Department of Health are working on, and I've raised that in my notes as well, and that does need to be sorted out. That law does need to be repealed. But you know, there's a lot of good work, and the next stage is to make sure that we have mental health and wellbeing education in the curriculum, and social and emotional learning and consent education as part of our Violence Against Women and Girls strategic framework. That needs to be in schools as well, you know, so that our young people get the best possible chance. And in the other regions, they're getting that. Wales actually made it mandatory for all schools to have that whole school approach. So, and it really, really makes a difference. England are moving to wellbeing teams, and 60% of pupils will have access to wellbeing teams. So making sure that schools, a safe, secure environment for pupils is fundamental to all of this. But they shouldn't be providing mental health interventions. It's not about it's about delivering education. You know, that's the difference. But kids need to be regulated in order to be able to absorb what they're getting. And if you're thinking of a third, potentially, of kids in classrooms with some sort of neurodiversity, that needs to be acknowledged, taken on board.
That's really helpful, you know, all that what you've provided there. It actually gives us some food for thought in terms of our...
And the hope-enhancing strategies as well, you know, helping young people set goals, understand their own strengths, and give them the confidence that they can achieve, that they can... that they can get the best out of their education, that there's a hopeful future for them. There's ways of doing that in a school setting, and I think that would be really important development. Other schools in Denmark, they teach kindness, you know, and it's kind of part of that as well, because it's all of that stuff.
Something that we could do with here.
And all MLAs on it.
I wonder on that, just if you could, like, we know that there was some discussion, there was a number of external organisations that withdrew from the Department of Education's working group on the restraint and seclusion workplace. So I don't know, we're not education, but it sounds like from your perspective that you also have a role to play in that, so it would be helpful for you also and us in the Committee on Education to engage further in the future.
And Department of Health are still involved in that process, as far as I'm aware, you know, to make sure that any guidance that's produced is trauma informed, and that it's trauma aware, but the law itself needs to be changed.
Yep.
You know.
Absolutely.
Could I bring in Diane? Sorry, is next.
Thank you, Chair. And thank you for the information. Can I take you back to the point that Nuala was exploring about neurodivergence and the 28.3%? Am I right in saying that you have calculated that against screening advice rather than against the number of pupils or people who have been diagnosed? It seems a very generalist way to come to a 28.3% figure, which seems to me enormously high.
Absolutely, it is a high figure. So it's based on a survey, a population level survey, and the survey included questions that are screening questions. So if you hit a certain score there, it's likely that you have autism or ADHD. So it's not the same as a diagnosis. We also
There's a lot of presumptions though in that.
Yeah,
that
there is, yeah.
people will have answered questions in a certain way, or sometimes people answer surveys, they don't even actually think that terribly much about them. It just seems to me that to throw out a figure of 28.3% based on a screening survey is a very generalist approach to it. That's the only point I want to make, because I actually was looking at things from the Office for Statistics and so on, about the amount of robust data there is around mental health in Northern Ireland. Do you think there's enough?
There is quite a bit of mental health data for Northern Ireland. We're currently producing a report at the minute. It's going to be available soon. End of the year, at this side of Christmas. So the fundamental facts document that we produced along with the Mental Health Foundation a few years ago, it's like an update of that, but we're adding in much more up-to-date data basically from these sorts of surveys. And you're absolutely right, Dan, that the surveys give you different results depending on what type of questions that you ask, and a lot of these young people wouldn't have a formal diagnosis, and you need that psychiatric input to make a formal diagnosis. But I suppose what I was saying is that this gives you an indication of the level of need, and the fact that these screening questions correlate with increased levels of poor mental health is, that's significant, and that's something that I have to be across. But that prevalence...
But being neurodivergent doesn't mean you have a mental health problem.
No.
Yeah.
Although it
means you might be more likely.
Yeah. Although ADHD is classified as a mental health problem as well, it was classified under the DSM as a mental illness, but our sort of more modern understanding of neurodiversity is it's a general variation in the population of how we think and process information. But on one end of it, you do have people who are autistic, who have a lot of difficulties and would need mental health support there as well. But we now see them as two separate and different things, and you can be neurodivergent and have really good mental health, but there are these trends towards higher rates of mental illness, yeah.
It's just that I do worry about a statistic that is maybe inflated, being used as the statistic in relation to this issue. I absolutely 100% accept that we are seeing more young people who are neurodivergent. I absolutely accept that, but I'm just really careful about how we arrive at the statistics that we're using. Can I just move on, because I'm conscious that the chair's going to shout at us anytime soon, or maybe he's not as bad as the vice chair, but maybe he's not as bad as the chair.
Chair's still here.
The issue of the sort of scrapping of 80% of the mental health strategy. I mean, that's sad in many ways for all of us. We are annoyed by that. What communication, discussion, etc., did the department have with you before that came about?
So even the way that the 80% thing has been highlighted, it's actually more than 80% is what we've only funded 1% of the whole funding that was there.
No, I accept that entirely.
It's actually probably much worse than that. I was involved in the deliverability review to the extent that I was interviewed in depth about all of the actions in that strategy and my thoughts on if we had to prioritise them, which ones would be prioritised, and that engagement was really, it was deep. And then when I saw the report, I was reassured by that, because it really did reflect what I was saying, but there were so many other groups that were involved in that as well. I've also had numerous meetings with the officials from Department of Health around the plans and reviews, around the implementation plans that were produced for each year. So there's the strategy and then there is an implementation plan. And I would have had discussions around what, you know, if you had to do anything, which ones would we implement? How should we take that forward? I'm involved in the groups relating to a lot of those actions, particularly the Regional Mental Health Crisis Service. I've been at all those meetings. I've presented, I've summarised what has been said in the room. So I feel I've been really involved in that. No, I haven't been involved in the decision about funding, and that's where the 80% comes from, though. So it wasn't my sort of decision to scrap a lot of it. But
oh no, Siobhan, I don't actually, I'm not saying it that. All I want to have is a reassurance that there was communication between you and the departmental officials before this particular fairly drastic step was taken. That's just, I want to have the reassurance that I accept entirely that this is not where you or I or any of us would want to be.
Yeah, and I mean, this is the 80% figure is based on the two priorities, I suppose, or the other. There's 5 more sub priorities. That's where that's kind of coming from. But those priorities are not going to be funded. I suppose is the point that I would want to make as well, and that's really worrying.
Yeah. So the other thing, I asked questions recently about overcrowding, really, I suppose you'd call it, in mental health wards. So some of the wards came back to me around about 123%, you know, so they're 23% over what they said versus what the recommendation is for a mental health ward. And I suppose, I would like you to maybe just fill us in a little bit more about the impact that you think that's having on inpatients, the impact it's having on community resources, and the impact on patient outcomes for mental health. I mean, are we really bringing about poorer outcomes because of this overcrowding? And what do we need to stop the overcrowding? Do we just need more facilities? How can we help you? How can we help to talk about this at a more purposeful level?
So the guidance for a psychiatric ward, it should be 85% should be the max. You should always have capacity in case there's a lot of people in mental health crisis that need admission. So it actually should never be even nearly at 100%. When we go over 100%, and I'm looking at the psychiatrist briefing, the Royal College of Psychiatrists that they provided me with, and I met them a couple of weeks ago as well. When psychiatrists are telling you, and it's really radical when psychiatrists are telling you that this is influencing their decisions about treatment, about admission, you know, that's significant. It means that they have to make really difficult, if they don't have beds and somebody needs to be admitted, they're sleeping in a chair, for example. I mean, I couldn't sleep in a chair, like, you know, and imagine someone in mental health crisis having to do that. It creates chaos.
Are we saying that seriously unwell patients can't get a bed, or 2, I don't know how to describe it, are sent home in the hope that it'll all be all right?
The psychiatrists are saying I mean, if you look at the press around that survey, you have significant numbers. And moral injury is the phrase they're using, the moral distress, because they can't provide the type of care that they were trained to provide, that they know that patient needs. And some of that invariably will be around admission and getting a bed. So, and when they say bed, in some cases we are actually talking about a physical bed, but it could be a room, it could be a bed that's staffed. You need a certain number of staff, and the vacancy rates in psychiatry are like 30% in some cases, you know, or some of the figures I've been getting over the past years around 30% vacancy rates. So that psychiatrists particularly aren't there to consult the vacancies, and staff on the ground, there aren't enough staff on the ground to meet the needs of those patients. So they're not going to receive, they're not going to receive the type of care that they should receive. And they use the term safe staffing. It's not actually safe, never mind therapeutic. So the interventions are going to be affected by that, and in some cases there may be patients sent home that should maybe have received, although it's hard to pinpoint now the numbers or the individual patients, and the response rates and everything for that survey needs to be looked at. But it is significant when psychiatrists are saying that this is affecting their provision of treatment and care. That's really, really concerning. And you can imagine yourself if you were in an overcrowded ward, and these are people with mental health conditions, and they need stability. They don't benefit from chaos. They need stability, routine treatment and interventions, and they don't receive psychological therapies as routine in a hospital setting, but many of them would receive de-escalation and treatment there and stabilisation, and it's not the sort of context that you could deliver that sort of care in.
Is there any data that helps us understand the impact of multidisciplinary teams, and particularly the provision of mental health people within those in the GP surgeries where they already have existed for a little while? Is there anything that's up to date in relation to that?
Well, my fishes are flicking through here. There is data. I don't have it in my... So we'll get it for you. So my summary of it is that MDTs are... The data seems to show they're reducing the numbers that are going into statutory services. However, anecdotally, I'm hearing that they are still referring people into statutory services. The worrying thing is that I'm hearing that the staff for those multidisciplinary teams are coming out of statutory services, leaving vacancies.
Yes.
So that's the problem. Yes. So whilst the numbers going into statutory services are going down in those federations or practices where they have the MDTs, and that's a good thing because not everybody needs statutory services. When I hear about even CAMS, the type of cases they're dealing with, serious mental illness, and a lot of people would be better placed in the community and voluntary sector receiving supports and services and problem solving type services as well. But if we come up with the numbers there, we'll let you know. They probably are in your briefing document, and we can get you those. But yeah, numbers are going down a bit, but where are the staff coming from? They're coming out of statutory services. That's a worry. We have a workforce crisis. Overall, 45% uplift needed for statutory C&V sector. We're waiting on the report on that. So
thank you.
Happy with that? Yeah.
Yes, thank you.
Thank you, Alan.
Thanks, Chair. Thank you, Siobhan. I was looking forward to this session today. It's coming very much at an opportune time for me, and I wanted to particularly focus on suicide in young people, and particularly some of the issues that can be done that doesn't cost money, some very simple tasks, and it brings me back to a very local issue but has a much wider impact. I have been dealing with a family. I'm not bringing any confidence here because this is an issue that has already been in the public domain, that has been across TV, newspapers. So this family lost their daughter in May of this year. This young girl took her life, age 18, and unbeknown to that family, the young girl had been presenting to her GP practice with self-harm, and there had been 2 instances in the past whereby she had attempted to take her life, and the family were entirely unaware of this. Now, we're very conscious of the fact that GPs have to work under very strict confidentiality and patient information sharing guidelines, and under various data protection guidelines. But one of the arguments that this family has been putting forward, that had there been an opportunity in which that GP practice, and I'm not criticising this GP practice in any way, I'm not, because I absolutely understand they work under very challenging circumstances, but had there been an opportunity whereby somebody in that practice, particularly the GP, could have made that family aware that their 18-year-old daughter had previous history, that she was concerned for their welfare. That family are adamant that they could have saved that wee girl's life in May of this year. And I've been writing back and forward to the department on the back of this on behalf of that family, and the department have referred me to this share document, which I'm sure you're very aware of, and I'm just wondering, on the back of some of the communications that I've been having back and forward to the department, initially it was my understanding that this was the go-to handbook right across the health service, but from my correspondence that I've received from the department, that this really has only been shared with the trusts, and it hasn't been shared widely within GP practices. And I suppose the question in this is, given that this should be the go-to handbook right across the health sector, including GP practices, is this something that you're trying to champion? I'm aware there is a meeting coming up now on November 17th with a zero towards zero suicide, and this is going to be discussed on the back of some of the conversations that I've been having. Are you aware of this, and is it something that you can champion? Because this family are determined that, you know, if their actions, on the back of their actions, can help save one more life and do not have to suffer the pain, the trauma that they're having to experience, then that's a good job done.
Oh, that's really, really important. What I would say, if they're interested, I wouldn't mind meeting with the family if that's something they would consider, just to get their perspective on it as well. The share guidelines are really good, and awareness isn't as it should be, and this is something absolutely that I would endorse, but also to say that the GPs are in a really difficult position with this. When someone's 18, there are confidentiality issues, and probably not in this case, but in many cases, the family environment could be part of the suicidal feelings and all of that. And there's many different reasons why it's sometimes not appropriate that you would share that, especially if the person's over 18. And GPs are bound with those confidentiality guidelines. And it's come up in university context as well, where a student is seeing mental health services in a university and then there's a suicide and the parents have never heard of it. And there's examples of that. So we do need to increase awareness of that it is okay, especially if somebody discloses that they're suicidal, that it is okay, absolutely, to contact parents in order to keep that person safe. And I'll do what I can to make sure the GPs are aware of that. But the other side of it is that suicidal thoughts are actually really, really common. Depending on how you ask the question, it's 1 in 5 people will say at some stage of their life they've had suicidal thoughts. And we don't want to put people off from talking to GPs and all that. So we just need to manage it all very, very carefully. It's very difficult to predict who is actually going to act on those thoughts. And there's no screener that has ever been developed that will work to predict. So what the NICE guidelines are now is that we don't use screening to determine who's going to get follow-up care. And that's the way it is. If someone says they're suicidal, then we've got to take that seriously. But then clinicians are obviously in the position where they have to make a decision about what they do based on what they've heard. It's a really difficult situation to be in. And that's why suicide prevention is everybody's responsibility in a way. We all need to be tuned in to the signs that someone might be thinking about suicide, and we need to know what services are out there that we can help people with, and we should be able to have open conversations about this. But look, I would want to speak to that family directly, and I'll be there on the 17th. It's towards the year of suicide. Incidentally, I've said in the briefing, it's really good. It's about safer care, but it's only statutory mental health services. And people who are suicidal, the GPs, all the contact that they would have, and that's, how do you get to so many people come with mental health crisis to the GPs, and many of us are suicidal or have lost hope. So what do we do with that? But thanks for raising it on,
Well, Siobhan, expect an email from me.
Absolutely.
Thank you.
Thank you.
Okay. Thank you very much for your presentations. I think we've got through a lot there today, so really appreciate that. Thanks to everybody for coming in.
Thanks. Okay. for.
Good man.
Okay, folks, is anybody any comments they'd like to add on the basis of that?
I think it's worthwhile just in a few months that there's a few issues that Siobhan had mentioned there that, you know, the results will be seen, or the first stage of results will be seen in a few months. So it's not, I don't think there's really a need to write to department or anything. I think it's something that we need to keep on our radar to bring her back, you know, next year early on those specific issues that she was mentioning. Yep. I wrote them down if you didn't. So.
Okay, folks, that was a very important briefing, and I know people had quite serious questions there, so I did let it go over. So just with the following briefings, if we could just keep our questions a bit briefer, just so we get through everything. Thank you. We're going to our second briefing today. That's the oral briefing from Northern Ireland Human Rights Commission and the Adult Protection Bill. Okay, so I refer members to papers at tab 7, page 264 of your main pack, and a memo is included in the table papers at page 88, outlining the key issues. So I want to welcome Ms Alyson Kilpatrick, Chief Commissioner of Northern Ireland Human Rights Commission, Dr Colin, Caughey, Director of Policy, Northern Ireland Human Rights Commission, and Dr Ivanka, Antova, Policy and Research Officer for the Northern Ireland Human Rights Commission. Thank you very much for coming, and I'll give you the floor.
Thank you very much for having us. You've already introduced my two colleagues whose great efforts went into preparing much of what you've had already, so I'll be asking them to deal with some of your detailed questions. I'll go straight to a very short opening statement because, as you know, the bill is quite complicated, and I think it's probably best left to you to ask the questions you want to ask. So, introduction of the bill, the Commission believes is a very positive step, and that it goes some way to addressing several recommendations from international human rights bodies and ourselves. The Commission welcomes particularly Clause 1, which outlines principles that a health and social care worker must have regard when performing functions under Part 1 to the principles set out. There is a significant overlap, and I think it's very reassuring for us to see that it mirrors essentially human rights principles in the criteria that's set out. The European Court of Human Rights has made clear the very essence of the Convention is respect for human dignity and human freedom. So we're very pleased to see dignity included specifically in the list of guiding principles. We do feel the bill could go further in making explicit reference to human rights standards. The Commission considers that expressly anchoring the bill within the national human rights framework would place the Department itself in a stronger position to ensure all statutory actors comply with their corresponding obligations when performing functions of adult protection. And this is consistent with recommendations from the independent review of Dunmurray Manor. And they stated advancing residents' human rights should be made explicit in safeguarding procedures, and we agree respectfully. In relation to Part 2 of the bill, Clause 32.5 provides that the Adult Protection Board must undertake such serious case reviews as may be prescribed in such circumstances as may be prescribed, noting the important role that such reviews can play in exploring the root causes of abuse. The Commission considers that the bill should provide further detail on procedural standards for serious case reviews, including requirements for independence, timeliness, public scrutiny and involvement of the next of kin in accordance with Article 2 of the European Convention of Human Rights. So all the arguments we often discuss about Article 2 investigations applies equally here. In relation to Part 3, the introduction of a new offence for an individual who has the care of an adult by virtue of being a care worker, to ill-treat or willfully to neglect that adult, and an associated care provider offence address one of the Commission's own long-standing recommendations. And it's repeated in our annual statement, so we're very pleased to see that. This measure will ensure, in our view, important protection for individuals, in particular persons with disabilities who are reliant on others for their care. In relation to Part 4, we note the installation of CCTV cameras can provide an important safeguard for those at risk of abuse. However, we recognise they can also present an infringement or interference with the rights of individuals, and I not going to take much for all of us to understand exactly the intrusion of privacy that can arise. That being the case, the Commission considers the human rights framework provides the appropriate backdrop in which decisions can be made on the deployment of CCTV cameras on a case-by-case basis. The Commission considers that Part 4 of the bill would be strengthened by expressly incorporating human rights considerations into the governance framework around the deployment, including the relevance of Windsor Framework Article 2. That's an ask. We repeat that Windsor Framework Article 2 is expressly considered in all forthcoming legislation and policy. Conducting human rights impact assessments before deployment can also provide a critical check and ensure effective decision making, which would go to protecting everybody, both those deploying and using the cameras and those subject to their oversight. We know that some of this is going to be supplemented by regulations and also guidance, so I think at that stage we expect that there is more we'll be able to say in relation to how, for example, CCTV is going to be used and regulated and monitored. But we do make the point at this stage, I think, that it is, there are the GDPR provisions to be very conscious of, because it is a processing of data. There is also the question, and I don't know the answer to this, it may be my oversight, about whether or not it's going to be covert or overt. And if it's covert, clearly the Regulation of Investigatory Powers Act might apply, and that needs to be considered. But all of this, I suspect, is going to be looked at in the context of regulations. So I'll leave it there. Certainly willing to ask any and every question you might have.
Thank you. You'd mentioned that the bill could go further by explicitly mentioning human rights standards just in the face of the bill. Can you explain what difference that would make?
There are a number of differences. I think one of them is to really put on the face of the legislation that human rights are part of the law. Sometimes I think it's overlooked, and people can assume that human rights principles have been taken into account in drafting of the legislation. It reminds everyone, including those for whose benefit this legislation is drafted, that human rights are the lens through which they need to see everything, but also all the public authorities and those private actors who may be commissioned by public authorities know that they've got to be thinking about it. I think it's about keeping it to the front of people's mind as apart from anything else. But what it also does is import, essentially, a framework of principles and jurisprudence built up over years, really good, sound jurisprudence that can then influence how this act is interpreted. I think, in my view, that's the real benefit of it. But I don't know if Colin, maybe Colin's done a lot of work on just this point.
I think it's really about with this bill, it's the implementation that's going to be the area where there's a potential slip up. So the greater reference we can have to human rights and human rights considerations, the more that will inform those decision making processes whenever the bill actually becomes law. So we're always in favour of more explicit references to human rights, although obviously this has been through a compatibility assessment, and the Human Rights Act will apply to the social workers who are actually exercising those powers, but greater explicit references we feel just influences those thought-making processes and actually prevents human rights abuses and infringements taking place in the long term.
Ivanka would like to add.
I'm going to be chiming in from the Windsor Framework point of view.
Okay.
And an express reference to Windsor Framework would just achieve centering this limited but very valuable additional safeguard to human rights in Northern Ireland following the UK's exit from the EU. It just means that it will be an additional safeguard against certain rights possibly slipping or against the diminution. So it's just an additional, if limited in its nature, additional safeguard.
If I could add just one last very short point on this. In terms of what is really welcomed in this, but also I think would be helped by express reference and tying it into the relevant places, the reference in this to the fact that it applies to those private actors commissioned by. I know some of the work we've done in the past with families, for example, of those in nursing care, whatever the setting should be. If it's a private facility, they've often been told that the Human Rights Act doesn't apply, and there's nothing the Human Rights Commission can do for them. if a person is a patient and a service has been commissioned, it does apply, but a lot of people don't understand that. So having that explicitly tied in is really useful, and I think a lot of families and a lot of people who are using the services are going to be really reassured by that. It applies to everybody.
I know that you recommended adequate resources allocated being to people with powers and duties that are then trained so they understand human rights implications of their work and operate consistently within a human rights-based approach. Under the Northern Ireland Act, Section 69, subsection 6, can you provide this educational assistance or financially assist to ensure that it is compliant with human rights standards? Would it have to be expressed in the face of the bill then in order for that to happen?
No, not in the face of the bill. I think the training should be considered essential. Mm-hmm. If you're asking social workers, health workers to go out and exercise powers additional to what they've been trained to do, and which may potentially carry quite significant risk to them and to others, but also which involve quite intrusive use of powers in people's personal space, then there's a duty to have them well trained for their sake, as everybody else's. So I wouldn't like to go out untrained and have to exercise some of these powers that are being given to social workers, and I certainly would want to know exactly what I was being asked to do before I was asked to do it. In terms of whether we could assist, did I pick you up right? Whether the Commission, we certainly are. We're always keen to help in relation to advice on guidance or what the human rights framework would be around a set of regulations. In terms of actually getting into the weeds of public authorities' policy documents and training documents, that's not really for us. But we certainly have a role in guiding and steering in the right direction in a human rights compliant way. And once the regulations are drafted, then there's a lot we can do. Colin might, part of it is also just resources as well. So if we had a lot more resources, we might be able to do a lot more. But do you want to, Colin's been at the Commission longer than I have and has seen some of this through many different policy changes.
Yes, as Chief Commissioner said, resourcing would be the concern. So we have previously worked with some public authorities where we've provided some bespoke training, and we have a general statutory duty to promote human rights and to provide education in human rights. So if there was adequate resourcing, it could be proposed to our commissioners that we would be involved, and certainly we would respond to any requests for advice that we see from the Department of Health in relation to the regulations or any of the training programmes.
Thank you.
Thank you very much for the presentation. It was very helpful. I've been looking forward very much to this bill coming before the committee, so a couple of points that were raised were very helpful from my perspective. I want to focus on a couple of things: the serious case reviews and CCTV, and kind of simplify. And I know that there's human rights implications, of course, a right to private life, but had it not been for the CCTV that was uncovered when it came to McMurray, we wouldn't know the extent of a lot of the abuse that occurred there. And I often have conversations with people and ask them, would you put your relative in residential care if there wasn't CCTV? You know, and the answer, always off record, is no. You know, how can we make it happen within the human rights framework to enable CCTV to be mandatory? Now, and I know it's not always as easy as that, but in terms of how we can make it happen so that it is mandatory, how can we use human rights law to enable that?
Well, it depends on somebody appropriately qualified and looking at all of the circumstances in which you would be mandating the use of CCTV to decide it's necessary for the purposes of protecting life or against inhuman degrading treatment, torture, etc. Once you consider that there is an obligation to install CCTV to protect in that way, then it would be a requirement to legislate to make that provision. So that would be the way you would look at it. If it is required for the protection of life, then you can insist on CCTV being held. Now, that's one part of it. There then becomes a whole other part, which is the use of it, the recording, the keeping of information, what you do with information, and that's a whole other side. So if you're talking about essentially live streaming or recording everything and somebody watching everything that has got back, that's going to be significant concern.
Okay.
And we would really want to get into that in more detail. But if what you're talking about is having access to CCTV, should it be required to go back and look at something, that's a different situation. But then also
that is what I'm.
But you have to be
referring
very specific about that then, and you have to, and that's why I was asking about covert and overt and the application of RIPA. It's a lot more complicated than just saying, surely if there was a camera, a person wouldn't misbehave, or if there'd been a camera, we could prosecute them because we'd see what they did. There's so much more to it than that, and I think it's a lot more sensitive than that. But it can be done lawfully, so long as you have very strict controls and within the law in relation to accessing the footage, storing the footage, processing it, etc. The one thing I would also say is I have some experience of surveillance cameras being used in policing, and there is a danger that whenever you have cameras there, that the default position is to have them running the whole time and to be watching the whole time. Because one, it in the person's mind eliminates the potential for false complaints, or it's going to protect. But what it also will do is expose to some of the most intrusive surveillance you can possibly imagine if you think of it in a care or health setting. So if you try and put yourself in the position of the person who either is receiving treatment or care, or their loved one being there with them, being watched with the potential that that is going to be kept and watched by somebody else, that's when you start to plan properly, I think, for the protections. So I think it's too easy, I think, to think that it's only there for protection and therefore it's an intrusion which we should simply put up with. There's so much more can be done to make sure that it is there to protect, but it is also controlled very, very closely. I know in this RQIA is expected to be carrying out some sort of the oversight of that, which is welcome that somebody does. I do think somebody needs to look at, and I'm hoping when the regulation comes through, whether or not things like the Regulation of Investigatory Powers Act applies. You may also have situations where a person is brought in custody. There may be a situation where a person is, there's a police officer sitting in the room with them, and it would be equivalent to covert surveillance of a police interview, or someone might come in that's listed. There are all sorts of situations that you really do need to think through in advance. So I think the knee-jerk reaction to cameras were useful in one case because it proved something that we couldn't otherwise have proved, needs to be really tempered and just made sure that it is really achieving the purpose.
And even if the cameras were, for the purposes of if issues were raised, and obviously in communal areas, would that negate some of the issues that you raised? And the last question, CCTV, is then, are you in agreement then that it's the regulation making powers is the right way to go down for kind of the regulating CCTV and the use of CCTV rather than mandatory on the bill?
Yeah. Once those who are charged with actually deciding on whether or not you want to have to mandate CCTV cameras in these settings, then you look at the regulation, oversight, monitoring, etc. of their use. But you also have to think about where you put them. So if you're limiting it to communal areas, if that's what you're thinking of, that is there are different considerations. But communal areas may still be a private setting, and there still may be privacy involved. And I think just a friend of mine recently, he was one of the unfortunate people who was treated in a hallway, which was a communal area. So that becomes a very private area, potentially. If you harm is often, particularly if there is a malign intent, harm is often caused in unexpected places. So it's not, you need to be very careful about what it is you're trying to achieve, but you can do it. You can have coverage.
Well, we were told, I obviously understood that it would always be difficult, but I mean there is a reluctance for mandating it on the face of this bill, and a lot of the reasons that we are getting is because it's too complicated to be done. But it sounds like that if that was something that the department would do, would they then engage with the likes of the Human Rights Commission to see how it can be done?
Yeah, perhaps I can say this, it would be a lot more complicated for the department and for all public authorities using it if they didn't engage properly and they didn't have this all planned out in advance. That's when it gets really complicated.
Have they engaged yet on it?
No, not yet.
Well, see, we were told that they couldn't put it on the face of the bill because of all the various reasons, but actually it sounds like, well, actually they could if there was engagement.
If there's a political decision, if a consensus is reached, that you want to legislate for this, unless there's a reason why it would be otherwise unlawful or incompatible with human rights, then there's no reason why you can't do it on the face of the bill. What you then do with the use of it is that's the next stage.
Yeah.
At that stage, then other laws may apply, but also the bill, the act that mandates it would need to also contain the safeguards and conditions and all the rest of it. But it's not. Maybe I speak too soon, but I don't see it as being necessarily difficult. CCTV is part of our lives now, and it is used in many different settings, and we have regimes for the processing of it. The police could give a lot of advice because they have body-worn video and they have it in custody.
Police want this to be mandated for.
Yeah.
They have their written correspondence to that effect. But if it is not on the face of the bill, but it contains regulation-making powers,
I think that is more difficult. I think we would probably say that nearly always something should be founded in a piece of legislation which you can read yourself. You can see, members of the public can read and see the very foundation of the law that they're being asked to comply with. It does allow for proper democratic scrutiny, and it can then give rise to regulations. So we would be less comfortable with something that is probably one of the most intrusive elements of this act, and we're saying that's not necessarily unlawful, but that it would be done by regulation, not by the act.
And well, I think that's very interesting because I mean it's what we Alliance had wanted. We've done work with the police on this at the policing board, following McMurray, a number of issues, and it's just not what we're hearing from the department. And I am very concerned now then that this is left out. And if it is not on the face of the bill, and this is, I'm just elected for the first time this mandate, so if I'm asking questions that might seem a bit stupid, it's because legislation is still new. But can it actually be mandated for in regulations, like to the same extent as what primary legislation is? Like, can we have the same effect?
I'm not sure, but my gut and experience tells me it would be very difficult.
Okay.
And it would be certainly open to challenge, I think, because it is what you're doing is removing or certainly restricting a very fundamental right of a person to privacy, particularly in the most intimate setting. But also the people who work with them to go about their work without fear that somebody's watching over their shoulder all the time. So if you're going to do that, then it needs to be done in a very open, transparent way, subject to scrutiny, democratically solid, and in a way that you can then, you can amend in an open, democratic way as well. So whether or not it would be unlawful to legislate by way of regulation if there wasn't some underpinning power in the Act, I'm not sure, but it would be problematic, certainly, and you'd want to avoid it. I can be sure about that.
Okay, thank you. I think that's been very helpful in what kind of I've been pursuing all along. I did have questions around serious case reviews, but I'm not sure if we'll have time. If I'm happy to come back to that at the end. Okay. I'll follow up in correspondence.
We can, yes, no, absolutely. We will provide. I mean, we can provide more advice in relation to that. We'll go back and look at that. I think that's much more a sort of question of sort of constitutional law. I don't want to tell you something that proves to be less than accurate.
We can engage separately as well.
My experience tells me that it would be a mistake to do it.
Okay.
The examiner of statutory rules might be providing you with evidence in relation to the bill and could answer any specific questions on that. So.
Human law principles certainly require legality on the face of any intrusion. It's much more difficult to highlight legality if it's in a regulation which is not underpinned by a democratically obvious piece of legislation.
Okay, I think you got your answer there as well. Alan?
Thanks, Chair. Alyson, there, you said at the start about the Commission having concerns over CCTV, and certainly like Nuala, I would take the position of if CCTV hadn't been in Muckamore, there might still, that cruel regime might still be going on, and we know nothing about it. So the concern that you appeared to articulate was the infringement of privacy as human right. I would come from a position too that the protection of vulnerable people is must be a human right as well. So one of my questions is there a hierarchy of human rights? Is there some that are more important than others? But you also said, I thought it was a bit maybe ambiguous if I heard you right, Alyson, you said that the Commission would sort of back it on a case-by-case basis. So I'm just wondering, what factors would have to be in play for you to back and to justify CCTV in a particular situation?
I'm going to deal with that first part first, and then I'm going to ask Colin to deal with the back in a case-by-case basis, because I don't remember us saying it like that. So I'm going to ask Colin. He'll be able to tell me if I'm wrong about that. But in terms of hierarchy, no, and we certainly don't have a concern with CCTV per se. Absolutely not. And the reason I've just answered that question the way I did was because we accept that vulnerable people must be protected, which is why we welcome this bill. But that doesn't mean that you suddenly cast aside all other protections, and those vulnerable people also have a right to privacy. So, and you say in relation to Muckamore you wouldn't have known. Well, there are other ways to find out, and some of them might have been better inspections. Some of them might have been listening to some of the care workers, might have been listening to some of the patients and their loved ones who had been reporting these things for a long time.
Would it have been difficult to bring prosecutions in those circumstances?
No, I'm not disagreeing with you, but all I'm saying is there's a myriad of ways in which you can ensure that these things don't happen, but also that you can prove when they do happen that they have happened for the purposes of, and so that's why when I said you could mandate CCTV in all areas, so long as you are also aware of the significant intrusion in people's private life, and you have a means for making sure that that's not exploited and it's not misused. And it is, again, it goes back to, say, my mother was in a nursing home and subject to surveillance. I would not like it if I thought there were lots of people could sit and watch her in a private setting or subject to medical examination, or me having a personal conversation with her. So that's the way of thinking about it, that's all. But absolutely no, there isn't a hierarchy of rights. Sometimes some people's rights come before another person's in a particular circumstance, but that's depending on need. And if a person's vulnerable, they have a need, and human rights law requires you to meet the need. And sometimes that means our rights can be put into second place. But I think that might be what we were hinting at on a case-by-case basis. Do you want to deal with that? Did we say that?
Yes, in our submission we're having. So in discussing the right to private and family life, that's a qualified right under the European Convention on Human Rights, and interferences with that are permissible, provided they're pursuing certain legitimate goals, legitimate purposes, and one of those is public safety. So although there's a right is being interfered with, those interferences can be completely justifiable and provided they're proportionate to meeting that public safety goal. So in relation to the use of CCTVs, we discussed about a case-by-case basis, really because there's certain scenarios where different factors would have to be considered. So if it was to preventing patients from coming forward to receive treatment because they were actually concerned about CCTVs, particularly if it's intimate care and other issues like that, then there would be a question mark over whether that is actually assisting with public safety. If it's dissuading members of the public from coming forward to receive medical treatment.
That's a reason to reject it. That's a reason to oppose it. But I think my question is, under what circumstances would the Commission feel it was justified? What are the factors that would convince the Commission that, yes, go for it, we would back you having CCTV in that situation?
If I could maybe say there, that's we come back to what I think I started with, which is there are better people placed to decide if it is a measure necessary to protect the sort of people you're talking about. And it may be in some care settings and it may not be in another. So it may be proportionate in one care setting because of the particular vulnerability or capacity of the people there, and may not be in another. So once those people have made that assessment that this is something that is a positive element in protection, then so long as it is there's a legal basis for it, which there would be if it was mandated in this Act, and there is some monitoring and regulation around its use, then it's not that we would back it, it's that we wouldn't have a problem with it and challenge it. So it wouldn't be for us to back it necessarily, but it's only we flag when we think there's a concern. And so long as you get all those things in place, I don't see that the Commission would have a legitimate
I still think your
concern.
position's quite ambiguous on it, but
But I think ambiguity. You may say I'm ambiguous. What I would say is cautious and seeing both sides. So it may be there are going to be different factors in different situations. So it's not for us to say good or bad. It is for us to say if those people who have these responsibilities decide this is right, we then look at it and say have they complied with all the other obligations they have, and if they have, then human rights law isn't going to have a problem with it. But I know Ivanka wants to add something.
I just wanted to follow up really from my colleagues that from an EU law point of view, which probably is not going to help the ambiguity argument by the nature of its complexity, but the Court of Justice jurisprudence suggests that operation of CCTV cameras and human rights protection considerations are not incompatible. I think lots of people understand the necessity to protect lives, rights and lives. What would be important, however, is to balance the rights against the legitimacy, the importance of the aim in pursuit of the public good that is in question. I suppose that's what we mean when we suggest that a blanket approach to the operation of CCTV cameras may not always be the optimum human rights compliant way of thinking about them, where you have a case-by-case option, where you carefully consider the rights in question, the proportionality of the use, the additional considerations around the storage of the cameras. Also, the Court of Justice has suggested that there must be a live interest in having CCTV cameras. For example, having issues in the past may not always be seen as a live enough issue. So I'm not saying I'm not advocating against CCTV cameras. I'm just highlighting the fact that the Court of Justice has ruled that there must be live interest, and that if there are less obtrusive ways to be used to safeguard rights, to safeguard people's lives, that they must be explored first, because CCTV cameras, as my colleagues have highlighted, are quite obtrusive.
it's a big call to make. Who would make that call?
People with all the information. We don't claim to have all the information. So the clinicians, the directors of the care settings, for example, RQIA, the department would need to engage, and this is why we say all the work is done up front and it repays all that effort further down the line. They all need to get together and they all need to decide, first of all, is this something we need? Once they've decided that, then they need to decide how they want to use it and how they're going to protect people's other rights. And I come back maybe to, I mean, it's not a legal answer, but if you think of yourself, if you have to go to a care setting, the idea that you might be recorded and that film could be kept forever and looked at by other people, it's when you start putting your own self into the shoes, because people who are vulnerable or need protection, they don't abandon all their other rights. So we need to protect for them their right to privacy. It's not. It wouldn't be. The call is by those people who have all the information, know the patients they're dealing with, they know the setting they're in.
A lot mechanism that you've just identified of all these people who have all the knowledge, would that be enshrined in the legislation?
Well, I don't think that needs to be. I mean, the oversight is in the legislation, or should be in the legislation, as to who you would actually want to carry out the monitoring and the regulation of this, which is the RQII, which is what you've said, I think, and then subject to the regulations. So the regulations presumably will talk about the other laws that already apply to the monitoring of personal data and the use of CCTV. In terms of who makes the decision to put it in, that's going to depend on, and again this comes back to the case by case, why we can't give you just a conclusive yes or no answer, to the sort of setting that it is. Who makes decisions in relation to that setting? So who would decide on any equipment that goes into a care setting? It's not us, it's the people who are running that care setting who are responsible for the people who are in there. And that's going to be from the department down through all those agencies that provide for those people. All we do is look at the protections around the interferences and make sure that they are lawful. So we would look to somebody else's decision making first and approach it after that.
Thank you. Thank you, Chair. I'm going to start with a request. You see, the next time there's a presentation, Colin, can you sit over there? Because the amount of times you've pointed and said Colin's an expert, and I've been like, what? You want me? I don't know anything about this. So it's perked me up a few times during that meeting or during the presentation. It looks, I think from this bill, actually, we're probably going to end up overemphasising on the CCTV element and the others, because it really, in a sense, got us to why we're actually having the bill. It feels like that the issues that happened in Muckamore. But it's just a very short technical question, which is, it was raised with me just about how CCTV gives you, in a sense, one dimension, which is just the actual, the movement of people. It doesn't actually always indicate what they're doing, what they're saying, what the interactions are. And I know that obviously in everything there can be two sides to a story. So what actually said, so now that we have CCTV images that can, or CCTV that can capture sound as well as images, is there any differentiation between that? Is that viewed as being more intrusive, or is it viewed as being, is it just CCTV whether it has audio or not? Because I know just that sometimes you can see something on a screen, but if you actually heard what was being said at the same time, it can give you a completely different interpretation. So is there any difference?
The more data you pick up through the CCTV, the more intrusive that is necessarily as a matter of law. So if you're also hearing what's being said, and you could be hearing somebody exchange medical information,
yes,
or talking about a personal relationship that has nothing to do with protecting the other person in the room. So it is certainly more intrusive. And again, I think the police, how they develop their surveillance in police custody cells might be quite useful, because they've addressed an awful lot of that. And through the policing board, I know you mentioned the policing board earlier, some of the work they were doing there with their human rights advisor. But I think the other point I think it's important, and you just reminded me when you said that, because it's so important that we remember this is not just about care settings. This is also applying to somebody visiting someone in their home. And when I first looked at this bill, I wasn't thinking of a care setting. I was thinking of somebody coming out to my house and forcing entry, for example, because they think I'm in danger, where you won't have CCTV. So if you get too hung up on CCTV or think that CCTV is going to prevent, I think you can get very lax with all the other. And as I say, the CCTV may have, in this one case, have caught, but the CCTV in the Muckamore case didn't stop it happening in the first place. It allowed it to be prosecuted, but it didn't stop it. And I think you need to also remember that there's the prevention, and what rights do you give up to protect others? And that's a balance. That's not for us, so long as it's within lawful range. But the more you capture, the more intrusive, and the longer you keep it, the more intrusive. The more people who can see it, the more intrusive, etc.
I didn't know it was on in Muckamore.
What was that?
They didn't know it was on the CCTV.
Yeah. But the fact is, it was there. It wasn't. It wasn't that Muckamore happened and it wouldn't have happened.
Yeah,
if-
no, I know. Yeah.
So that's
but
all
I
I'm
think
saying.
it's also an important note, like, because it's something that the families always say is like,
Yeah.
they didn't.
It's also years and years ago working in the youth service and in our centre we had CCTV, and all that actually happened was that the kids worked out exactly where it wasn't covered, and that's where they went if they wanted to do something that they didn't want to get caught, and that's what it can do. You'll never cover every square inch of a place, and if somebody wants to do bad, they'll find the place that they can actually do it. So it's also about the culture and about the protections within the organisations and the sort of oversight of it, rather than it just being the CCTV. But
Sometimes you can give people false confidence
yeah,
if there's CCTV. And also, just I'm a lawyer, and I've spent a lot of years in courtrooms. It is easy to argue over what is right in front of your eyes,
yeah,
but
yeah.
what the context is, the wee bit that you don't see on the camera, what was actually said and not said, what was said before. So it doesn't always provide the answers, even for a prosecution. So there's a note of caution just as to how effective it might be. We're certainly not saying it isn't. It's for others to decide that, but once you decide it is effective, then just make sure it's regulated properly.
Okay, that's been very useful. Thank you. Thank you.
Thank you, Colin. Thank you very much for that presentation. I think there's going to be a lot more questions, a lot more engagement, and the clerk has just highlighted to me that the PSNI are coming in December, so we'll be able to discuss that aspect of it then as well. Thank you very
Certainly
much.
be worth asking.
Yeah.
I was doing some work with the policing board at the time
Yeah.
and the body-worn cameras, but also the custody surveillance. And I went and watched. So the public protection unit, I think, would be one of the likely ones to come and see. It might be worth asking them about the guidance they introduced. If you haven't seen it already, because it was subject to human rights assessment on the use of the cameras. It just might be very helpful. It might
Right,
short
thank you.
circuit things a little bit.
Hope you're not suggesting we should get arrested and then try and find out how this system
Do
works.
some field work.
Go undercover.
We're not offering to do that for you.
Thank you.
Thank you very much.
You don't want to what is it they call the join the police for a night out on their. I don't know what's it called. Ride along. Was I going ride? It's not that.
Have you been in one?
No, well, is it good? Is it?
Okay, folks, have we any comments to make during, just in relation to that?
Yes, I think it's worth exploring further as a committee. This issue of the CCTV, this is obviously the first presentation, so I'm not going to jump, into, do a committee amendment straight away. But I mean, we've raised it, all members have raised it before, many times, and I think it was when Robin was last here about it. He was the last member, really, our minister, who came about it, and I do think it's something worth us exploring as a committee. I'm just obviously not sure how process works because I've not done committee stage before.
Maybe something we can come back to later on through the working of this bill. Members may be aware already, the Minister has recently announced that pay parity is to be delivered for healthcare workers there this afternoon, and that the pay uplift in the back pay will be in their February 2026 pay packets. Just so I'm sure members will be interested in hearing that. Okay, folks, we're going to move on to item number 7, which is an oral briefing from RAISE on the Adult Protection Bill. Thank you very much, folks. So we have Sinead McMurray and Grainne Crealey from RAISE. This is a closed session and will also be held today.
Just saying that a closed session will be held later.
Oh, closed session will be held later regarding the bill as well. And this session will be an opportunity to ask any questions or clarifications to the bill clerk. So welcome to Sinead and Grainne from RAISE. I'll invite you to go on ahead. Thank you.
Much. I'm very glad the Human Rights Commission were up first to talk about the CCTV because it definitely is something that's been subject to a lot of controversy. So this is to provide an overview of the two papers that are in your pack that are based on the Adult Protection Bill. The first one is an overview of all of the clauses and stakeholder responses, and a review of experiences elsewhere in England, Scotland and Wales and how they have implemented their legislation. And then the second one is on the financial implications of the bill, which Grainne will take you through. And I'll take you through some of the commentary from stakeholders and other experiences. So the bill is quite lengthy, it's 5 parts and there's 51 clauses. So what we thought, that rather go through the clauses each clause now today. It would be better to maybe just provide an overview of some of the cross-cutting themes that have emerged, that maybe will give rise to some thoughts then later on. And obviously we can come back at any stage and prepare more research if that's what you guys would like. So to start off with, one of the first things that we noticed from doing a lot of the research was how stakeholders had flagged is the importance of the statutory guidance. So clause 22 sets out that the department will provide statutory guidance around a lot of the operational functions of the bill. And stakeholders have highlighted, I suppose, the importance of that statutory guidance in terms of its quality and its depth. And that's been raised pretty much by every stakeholder who will be involved in safeguarding duties, whether that's protection orders, duty to inquire, all the various parts. So much of the commentary and the queries that have been raised in relation to the bill are around those operational matters. So things like how definitions will operate in practice, how multi-agency cooperation will work in practice under clause 4, protective powers, how all that will work. And I suppose most of the answers to those questions are going to be in the guidance rather than in the bill itself. So in some ways it's difficult for stakeholders to comment, I suppose, fully on the bill because a lot of that information is going to be in the guidance. So the department has indicated that they are, I think it was at the last session when they were here providing evidence that they are developing those resources alongside the bill. And there are good reasons for having a lot of that operational detail in the guidance, because it can obviously evolve as circumstances change within adult safeguarding, for example. The emergence of self-neglect and coercive control as areas of harm. They're relatively, I suppose, new areas that are being considered as areas of harm. So there is good reasons to have them in the guidance, but I suppose what a lot of the stakeholders have highlighted is that they really would appreciate early sight of that guidance, and to contribute fully to that guidance, like for example some of the regulatory bodies, I suppose, to see how the guidance will match up with their existing I suppose duties under their own guidance and their own say ethics considerations and those kind of things. So certainly the statutory guidance was an important factor. And another thing that has been, I think, consistently came out in what we looked at was the clarity and consistency around definitions and terms. So this is an area that has, I suppose, demonstrated significant commentary and, what key terms will mean in practice. So terms like harm, undue pressure, adult at risk, capacity, gross breach. There are a lot of different terms used throughout the bill. And you could spend a full session just talking about one particular term, but I think what was common through all of it was the need for really specific guidance, really specific training, really clear to all practitioners how those terms work in practice. So for example, if you look at capacity, the queries are around, well, how is capacity, they use capacity in the bill, but there's no explicit definition of what capacity actually means. So how is capacity going to be defined? Who's going to judge that capacity? Is that going to be, what professionals are responsible for doing that? Where is that going to be set out? How is it going to align with, say, the Mental Capacity Act? There's a lot of questions around it, and I think the main reason for that concern around the various definitions is that if there's ambiguity around the terms, and this is very much the experience in England, Scotland and Wales, it results in, I suppose, it can have significant implications. So for example, if you take the term harm, if each of the trusts are interpreting the term harm differently, it means that there will be different thresholds for intervention across the different trusts, which then in turn leads to that kind of concerns around a postcode lottery, that people in one trust are getting a different adult safeguarding experience than, say, those in another. And again, I think that's the experience in a lot of the reviews that have been carried out in the legislation in England, Scotland and Wales, is that professional confidence and competence in terms of applying those terms, and being confident in using them and being confident in what they mean. And there were lots of good sort of, I suppose, examples of things like, practitioners are saying we need really clear case studies, practical examples of how to apply it in different circumstances. And I think probably no guidance is ever going to be perfect, because every safeguarding case is going to be different, but having having as tight as possible definitions and clear guidance for staff and training can reduce some of that variance. And I suppose learning from the experience of other regions in terms of that. And then I think the third sort of point that emerged, and it's in keeping with that sort of consistency and harmonisation across trusts, there was some research published in Queen's recently that found that there was a social gradient along with adult safeguarding. So there was higher adult safeguarding referrals and adult safeguarding activity in areas of higher deprivation, and also in care homes that were in areas of higher deprivation. There was more adult safeguarding activity. And I suppose that probably needs to be borne in mind, and Grainne can talk about this in more detail, but when you're considering resourcing and equitable resourcing, and whether those areas who are experiencing higher levels of safeguarding activity would have resourcing to match those needs. And similarly as well in rural areas, it's well established that rural areas more generally have difficulties accessing health and social care, and so how will that work in tandem with that needs to be borne in mind with adult safeguarding as well. And then linked to the idea, I suppose, of recognising that there are certain areas that will have higher levels of safeguarding needs is the idea of data. So with one of the duties of the new Adult Protection Board is that they are to, I suppose, identify trends and learnings, but there is no explicit, I suppose, content in the bill itself about how that's going to take place. And I suppose there are some good examples from Scotland. Scotland have a data set. They record various metrics around adult safeguarding, and they use that data set for planning, and it has been suggested that has improved transparency and it is helpful for planning, and they publish those metrics on a regular basis, so it may be worth exploring what kind of data, and obviously there's the GDPR considerations and everything around that, but what kind of data is the department actually going to employ, I suppose, to track how safeguarding is being implemented after the bill, and I suppose how cost effective it is. And again, a point worth noting actually with the Scottish data set was they did note that the data set is well embedded, but one of the issues that has consistently come up is that the variance in the way that harm is interpreted is affecting the quality of the data. So it's again back to that consistency about terms and the need for really strong guidance and training and support for practitioners who are going to be implementing those safeguarding duties. And then we had some information on the CCTV at the end, but I think that's been well covered. But I think just in relation to what the Commissioner was saying in terms around the principles of the bill and human rights and respecting the autonomy of the adult who is being safeguarded and respecting their right to be involved. The department there's a provision within the bill that they have to provide an advocacy service for somebody who's being safeguarded, and there is evidence from Wales that demonstrates that advocacy can improve the experience for the adult, it can build trust, it can support the whole communication process, particularly when there's multi-agency multiple agencies involved in a safeguarding case. They can kind of be the voice for the adult, but that oftentimes advocacy provision is less than optimal. So inconsistent referral practices, insufficient commissioning in some areas, advocacy coming on too late in the process. So the learnings seem to be around that the advocacy has to be timely, so it needs to, and there isn't any indication in the bill about when that advocacy kicks in. So does it kick in at the beginning of a safeguarding journey when there's a duty to inquire, or does it come later if there are protective orders in place? It's around making sure that the adult receives it at the right time so that they can be, I suppose, as involved as possible in their care. And again, that advocacy would be available to everybody, not just in particular areas. So that whole idea of having consistency and harmonisation across the trusts. So that covers most of what I was going to say, but in a very whistle-stop way. Obviously, the paper is quite lengthy, so I think it's well over 100 pages. So there's quite a bit of detail in it, and we're happy to come back in and obviously discuss any of the clauses in more detail. But I think for now it was just to give an overview. And now Grainne, I think, is going to go through the financial.
Okay.
Well, my briefing dealt almost exclusively with the financial aspects of the bill. So, as outlined in the briefing, financial scrutiny is a robust process. So, it involves, first of all, you deconstruct the bill down into its component costs, you interrogate the assumptions behind these, and then you explore any uncertainty around them. As you can see from Table 2 in the pack, and it's again shown graphically in Figure 1, there are a range of duties and responsibilities which give rise to costs within this bill. Okay, so using the data supplied by the department, we can see that 3 main categories are responsible for approximately 80% of all anticipated expenditure, namely the staff costs related to the duty to inquire and investigate, training and capacity building to enforce the bill's provisions, and legal aid costs around protection orders and the proceedings that arise from that. In year 1, costs are estimated to be around 12 million. This is entirely new funding, so this is in addition to the gateway funding of approximately 17 million per annum. And so therefore over the next decade or so, the anticipated expenditure is about 120 million. So looking at the 3 cost generating events or generating costs in turn, first of all, the duty to make inquiries, that's the largest cost component at just over 7 million. It covers the employment of 135 staff in governance roles. These are primarily senior roles, 8A to 8C, and a range of band 7 roles and some administrative roles to support those. An area for consideration relates to the potential diversion of senior staff from frontline duties. This can create a cascade effect that could strain mid and lower level bands, putting pressure on the service, but also could lead to unanticipated, perhaps, agency spend further down the line. Questions for the department could include, have alternative service models been explored, ones which perhaps could protect frontline services, and in the same vein, has workforce planning been undertaken? Another point to consider is whether the proposed workforce model aligns with projected inquiries. In other words, the figure of 135 staff, is that related to the expected uplift in demand associated with the statutory duties? Okay, and what mitigations would be put in place in terms of if inquiry volumes were significantly higher than expected? Another key generating event is training, and the clarity and consistency of training and the rollout of training is actually critical to achieving the bill's objectives. Without sufficient training, there could be inconsistencies in practice which could drive the volumes of inquiries and investigations and ultimately feeds into the protection and safeguarding the outcomes that are achieved. The department's current costing model reflects lessons from other jurisdictions which already have this legislation in place. So there seems to be sufficient monies available for interagency and joint training. However, you may want to ask the department if this includes backfill. And also the other thing that I noticed was that the costs associated with training are front loaded as opposed to rather having a rolling programme over time to empower all staff really to discharge their duties effectively. The third main cost then is legal aid. And so the anticipated inquiry volumes are coming from Scottish data, but in Northern Ireland we might see a completely different pattern of activity. Questions for the department may include what modelling has been done to anticipate inquiry and investigation trajectories, and I'll come on to this in a minute or two. But for example, if it's assumed that there's initial surge in inquiries and then this returns to a steady state, this will have completely different cost impact as if there's a surge of inquiries initially and then this trajectory increases over time, as has been seen in other jurisdictions. So I suppose that also highlights the fact of real-time data collection and monitoring and how important it is to see what the inquiry volumes are and be able to mitigate and put in place changes as and when that happens. Now, a range of other costs have also been included in their cost model. IT upgrades to allow for interagency sharing of data, CCTV, as has been discussed, the Adult Protection Board and serious case reviews.
Currently, the costs associated with the Adult Protection Board are quite modest, but similarly, if the scope of the Adult Protection Board were to be increased, costs would also increase. And so that's keeping it sort of to a strategic and guidance level. Currently, CCTV costs are low, but operational uncertainty may drive future costs. As we've just heard, it's a very complex issue, and depending on how that would be rolled out and the different requirements, there's probably actually a quite substantial cost there that would have to be factored in. I think this sort of brings us back to the point which was made, which is secondary legislation and the impact that this will have on costs. Current key operational details, such as inquiry thresholds, depending on what definitions are used, the remit of the Adult Protection Board, the CCTV protocols, these will all be defined in secondary regulations and statutory guidance, and as such are not fully costed, as the detail is not there to allow this to happen as yet. So you may want to ask the department, would it be possible to provide a timetable with indicative budgets and impact notes to ensure those costs can be fully scrutinised? My last point is to do with modelling uncertainty. Now, that sounds quite boring and it's quite a technical point, but in reality, it's incredibly important. It's best practice to subject a cost model to uncertainty analysis. And so this is to test how the costs change over plausible ranges. So some variables are associated with not a lot of uncertainty. Say, for example, the cost of a Band 8A staff member. You know the trajectory and how it's going to change. There's going to be uplifts, inflation, etc. However, inquiry volumes are subject to an awful lot more variability. We're not actually sure how they're going to develop over time, whether there's optimism bias, behavioural change. And so modelling these trajectories and seeing how costs vary is actually a very important part of the scrutiny process. Currently, limited modelling or uncertainty modelling has been undertaken. This is not a criticism per se. The department have indicated that the option currently being considered is option 5A, where it wouldn't be implemented until such times as funding were available. And in addition to this, a more detailed business case will be provided as the legislation moves through. So I suppose to sum up, some of the finer detail of the bill is yet to be tied down at this committee stage, and so many of the decisions made here will actually have cost implications. Therefore, undertaking financial scrutiny at this stage is indicative rather than definitive. And so hopefully I've given you just a broad overview of, I suppose, the magnitude of the different costs contained within the bill, and highlighted some of the areas where some additional probing may be warranted. Okay, thank you.
Thank you.
If you have any
Thank both of
questions.
you. I did have a question about CCTV, but you had answered it, so thank you very much. I only had Nola to come in, but if there's anybody else has any questions?
No, it's just very comprehensive, and it's given us certainly food for thought about the financial ramifications of it, because sometimes you just think there's a cost, but then to actually start thinking about it in terms of which year those costs will come in and then what the ramifications to the future, and certainly the stuff about I think we've all had comment about the staffing in terms of what it's going to deplete the sector of staff and at a senior level, and then that's going to have to be backfilled, and if there isn't the right number of places in the background university to put people out. So there's definitely things there that we'll have to consider and ask the department for what their plans are in terms of delivering this. So, but no, it was useful. Thank you.
Thank you.
Thank you very much. Thank you for your reports and your presentation. Thank you. Okay. Hey folks, has anybody any comments they'd like to make on that?
Other than that, seems incredibly complex.
Agreed.
Your life slipping away in front of you.
Okay folks, item number 8, written briefing from the Department on Violence and Aggression against HSE staff. Something sadly I'm sure we're all very, very aware of, and I think you'll agree the statistics are appalling. So I'll refer you to tab 7, page 337 of your main pack. Has anybody any comments they would like to make on that? Okay. And on to our next written briefing is from the Department on Hospital Car Parking, and I'll refer members to the respondent list at tab 9, page 345 of your main pack. I agree it's quite a short briefing. Anybody, any comments they would like to make on that?
I've noticed they're getting quite a number of correspondences now from constituents saying that they've been bumped out of their car parking spaces and that they've been left because so it sort of feels like what we took in good faith as a bill here seems to now be causing car parking wars among staff out on the ground, and that's disappointing that they haven't been able to facilitate everybody, but that might be an ideal world. But it certainly seems that it's causing a sense of people feeling that they've lost out, which is not what the intention of the bill was from here, but it's the byproduct of it.
Yeah, and certainly I think we were due another briefing on this in the new year, and we could schedule an oral briefing so we would have the opportunity to delve into that a bit further. If members are happy. Yep. Okay, moving on to correspondence, item number 10 in your packs. So that's the index at tab 10, page 348 of your main pack. And the actions on the table then, on page 350 of your main pack. Has anybody anything that they would like to comment on there? No? No? Okay, folks, we'll move on.
I thought you were trying to force one of us to have an opinion.
No? Okay. No problem. Okay, folks. They have two actions that have been highlighted. So refer members to the correspondence from the Department regarding the Adoption and Children Act, Northern Ireland 2022. First reports at tab 10, 492 of the main pack. Any comments on that? Nope. And the second one then is correspondence from the Department regarding winter preparedness, tab 10, page 428 of your main pack. And is there any comments from anybody on that? I'm not seeing any hands up. No? Okay. So members are all happy with the suggested actions in the index? Mm-hmm. Yeah. Okay, folks, we'll move on to item number 11, the Forward Work Programme. Refer members to the draft Forward Work Programme, tab 11, page 708 of your main pack. Do members have any comments, suggestions or amendments they would like to make?
Just to get a clarification, I'm not sure whether I dreamt this or whether it actually happened. The Western Trust, they've already given us an update on the issue of the realignment of in their actual what's happening in the Southwest Acute. I remember their medical director was here and explained how there was changes and what the ramifications of those changes were. So we have had, I know we'll get another one, that's fine, but I'm just checking we already did have one, didn't we?
We were briefed on that, I'm trying to remember, it was May or June time, so it was, in relation to, we were briefed by the Trust and by RQIA as well.
Yeah.
On it, so we have had that initial briefing, and we'll certainly make sure that's included when we're down again on the 27th.
It's grand. It's just sometimes you feel you're going a bit insane because I think they're suggesting that we didn't know what the ramifications of their changes were, but I was nearly sure that they were here and actually give us a presentation, and we were dealt with that. So it's just good to know that. Thank you.
Okay, folks. Item number 12 then. Any other business? Any members? Anything they would like to raise? Diane, your hand went up there.
So, sorry, I tried to get my hand up when Colin was speaking. So I think actually it's a really good point, because the Health Minister announced, I think it was last week, that they would open the 2 uncommissioned theatres at the SWA. And it would be useful to have some information before the committee goes to Enniskillen to actually understand where the funding and staffing and the time frame is for that opening, and the precise nature of the work that they will be doing.
Thank you, Diane. Keith, you're happy to take that on? Okay, we'll endeavour to get members provided with that information before Diane. Thank you.
Thank you. Thank you.
Okay, folks, just in terms of any other business, I didn't have any other indications of anybody. So we'll move on to item number 13, the date of our next meeting. The next formal committee meeting is on Thursday the 13th, room 29 at 2 p.m. Okay, members, we're going to move into a closed session now. If I could seek agreement to move into closed session to look at the Adult Protection Bill and the consideration of Palliative Care Services report. Is everybody happy to move into closed session? Yep.